Okay, let's start the session because we are in a little bit delay, 2 minutes according to the... And then this session is quite long and interesting with various arguments. And I am very pleased to co-chair the session with Professor Adam. And we are then starting with the first talk by Fulvio Calise. He did a great job with our National Journal in Surgery, Updates in Surgery, an Italian way to a journal. And we will have Professor Bismuth as the first discuss. Pierre Alain Clavien that will discuss.
Be discussant. Well. Okay. Again, good afternoon. Well, thanks to Guido and to Hugo for this beautiful meeting, for all the fatigue that you have faced. I think the best compliment for this meeting comes from the staff behind here. When I handed my presentation, they told me, what a beautiful meeting. Finally, people that discuss, which is, I think, the secret of this company of Compagnons. Well, I start with greetings from my city, Naples. Allow me to tell just a moment the story of this lithograph that after having sought after, finally I could buy it. Well, this is due to a French, Alfred Gaston, who had a fantastic idea to buy an air balloon, and he traveled all Europe. Naples, Milan, Rome, Paris, Dublin, wherever, London, Berlin, and he paid himself. But the question is that for the first time, you have an overlook of what you are doing, and this is something that I think it's part of our job to have a global vision always, especially in this time of minimally invasive liver surgery. So this is a story. We are in Italy, and I thought that I should present our journal and what we have been doing. Also, hoping that my eminent discussant will not massacre me after this journal. But first of all, Lorenzo Capussotti, who started to be the director of this, and you all know, and was a great friend of mine. Unfortunately, he went away too soon. And then in 2015, I took the lead as editor-in-chief. This is the journal of the Italian Society of Surgeons that you know, and that the mainstream is to favor the progress in the exchange of scientific surgery and the education of young surgeons. This is in the documents of the Italian Society. So these are the facts. At the time, 2015, there was no Italian journal with an impact factor. There were only 3-4 journals published in Italian language. The Italian healthcare was considered the second best healthcare in the world after France. It was, unfortunately, because we are having a big drop down, and we have problems as everywhere in the world, but this is another story, with the surgical societies fighting each other, and most of the journals actually you cannot say they are journal where from. So, since this is the journal of the Italian Society, we decided. And as you see here, although we had a beautiful, a good healthcare system, we are only in the 6th place for journal, for scientific surgical journals. Before France, but after China, Germany, and so forth. So this means that we do a good job, at least as far as up to this moment, in our clinics, but we don't present ourselves. We don't share our work as better as we could do, as good as we could do. So my first step was to put together societies that could endorse updates in surgery. So to try not to fight, but to work together. These are the societies. I will not go into the details, but they are the 8 main big societies of surgery in our country. The second step was to enlarge the editorial board and to divide it into sections. I don't know whether this is a nice decision, but we thought that could help, to handle the many submissions that we receive. We shall see it afterwards. Then we founded a third, an innovative section, education, training, and methodology of research. And we trusted to Professor Montorsi, who is the dean of this university. Unfortunately, he has not been able to stay here and give you his greetings. If you look at JAMA surgery, in the previous editorial board, they had a clinical education editor, but now in the new one, this has been canceled. So this is, some JAMA surgery. It's something that tells the story about what a journal should be. But anyway, we will discuss a little bit. And then we decided to answer the call to action to surgery journal editors for diversity in the editorial and peer review process by Melina Kibbe and Julie Freshlak, editors of JAMA Surgery. And we published a foreword and recalling a poem of Emily Dickinson, that you all know, but we included, so we asked one associate editor, Anna Marteling in Stockholm, to take care of colorectal surgery, and we have the honor of having Laurence CHICHE in our advisory board together with other women. And if you see the gender distribution among surgical journals here, well, it's a complicated slide. It's very, I should look at, but it's unbelievable how women are a real minority in the journals, in the scientific journals. And we all know their value and what they are able to do. So this is our percentage. We hope to increase it. The American Journal of Surgery has even included the Association of Women Surgeons. I don't know whether this is good or not, but anyway, this is just to say that things are changing. We needed to implement the quality of published papers. I say this is maybe a provocation, asking supporting papers where we see a hole in the literature. We carried on as updates in surgery at 2 years consensus on synchronous treatment of colorectal and metastasis, colorectal disease, cancer with metastasis. 2 years according to the Delphi method, 5 national meetings, 5 societies included, and a staff that represented, we believe, the best in our country, according, as I say, and I particularly, I'm happy to present this paper that has been written by Guido Torzilli together with other colleagues, Felice Giuliante, and so on, because we have somehow years ago given indications for treating different, and after so many years, actually, we could foresee which are the current trends in pancreatic, esophageal, colorectal, thyroid surgery. The 6th step was to implement the number of published papers. So we passed from 4 to 6 and then to 8 issues, and also some pages for advertising. And since, as you know, we have a variety of we are a general surgery journal, so we have a variety of papers going from colorectal to breast cancer and 3D printing. So we invented this monothematic issues. We have produced 6 during the year with 2 guest editors, 1 Italian and 1 foreign, so that to focus on some of the most relevant questions that are on our, and all this only with the here 5 or 6 or 7 people. Just look what JAMA Surgery has in the organization of their journal. Naturally, as foundation is a private company, I don't know, but anyway, this is just that we must deal with what we have, and this is the trend in the real exaggerating trend in publications. I'm sure that any one of you receives every day letters asking for articles in open access journals. So let's briefly go, before I conclude, to our data. So we are more than 1,000. The trend is more than 1,000 in this year. This is our acceptance and rejection rate. That is not 93% of JAMA surgery or of annals of surgery, but because it's a philosophy, as I will say just in a moment. These are the review times, the publication times, the downloads, a lot of downloads. This means that there is interest in throughout the continents. As you see, mainly Europe, the papers submitted. When we go to the accepted, naturally, this percentage raises, but we receive anyway the majority of a paper from out of Europe and naturally of our country. And a lot of visits also. This is Europe, just to apparently testify. This is our impact factor. 2021 to more or less we are on the same line. You see British Journal of Surgery, because of some COVID paper, jumped 5 points. I don't know. I think that something should be done to change this mechanism, because, well, okay, my respects for British Journal of Surgery, but I believe that there must be some relationship between the continuity of publications, the quality of publications. I don't know. You all know that there are inquiries by Clarivate Analytics about fake papers, about fake authors, and so on. So I cannot go into the details of this, but this means these are our previsions by Scopus. I don't want to bother with you, but we are increasing our citations. But UPIS wants to go towards young surgeons to progress in scientific writing, disseminating its acknowledgement in the international setting, and in publishing innovative papers, not necessarily in the emirate format. That's what believed to allow the knowledge of the referral environment. And so, unfortunately, in our country, I don't know in yours, but medical writing is not taught in the universities, it's not taught in the universities, no full courses available. And so we started complete courses. This is the first, into 2021. I chose this painting by Picasso because it's the mother of François Gillot that takes care of her 2 sons, Paul and Paloma. And this is just what we should do, take care of our young surgeons and teach them. And this is in Rome. And then we went also in the university where I have the honor of teaching, in the center of Italy, and this is the next in Pisa. Then we organized in the congresses this call for proposal for papers. In other words, we discuss hypotheses of papers. We give suggestions, and if the papers are written, then they are submitted to Updates in Surgery. And then we have a journal clip, 22 sessions so far, it's 2 years. So you see the numbers, 2,000 participants, just to discuss papers that have been published in Updates in Surgery. And then we have Twitter. Okay, these are the followers up to June 22. It's not, sorry. And then we introduce the visual abstract. We do it ourselves if people ask for. Otherwise, they do it themselves. And we think that this is a good way of letting, understanding, advertising the paper. Just a few more words. The questions that we have on the carpet. Hybrid or open access journal. We all know the advantage of open access, but this is what the editors support, to go towards an open access journal, but open access has some drawbacks. And Alex, this in our country, the university have made an agreement with Springer, but not the hospitals. If we were an open access journal, people from the hospital should pay for the papers. And I must say that all these journals are hybrid journals, so we are in good company. To print or not to print, all these journals again are printed, also because we personally believe in manual reading, underlying passages, what we do when we read a book. We do. I presume it's good to do also when we read a paper, and so going back sometimes what we have been reading and stacking in our library, your continuity in your life. And as far as I will be editor, the journal will be printed, I don't know what will happen. Then this is the question that you know. ChatGPT as an author of a paper, where we will listen afterwards to artificial intelligence by Gianluca, but Springer has said no. We don't, at the moment, we don't believe that ChatGPT may be listed as an author. We may say in the material matters that he has participated, but this is a fundamental question. I hope that you agree. And then we have also made an appreciation of a journal, of our journal. These are the reasons why we should, UPIS is well accepted, the impact factor, the reputation of the journal, and so forth. I mean, we try to understand our work and compare also to the other journals. So, I mean, the results are quite satisfying. We can do better. We shall try to. So, in conclusion, updates in surgery is well established in the international setting. It's very young, 15 years old, but we have some ambitions to publish innovative papers, not necessarily, as I said, in the immediate format, to allow the knowledge of the referral environment, and to ask and favor papers that the editorial board might evaluate as necessary, encourage multicentric, prospectively, and possibly randomized studies, the best way, in our opinion, to try to get to the truth, to give our contribution to better organize the education of the future surgeons in light of the technological revolution, and also to serve somehow our authors. The institution of a section, education, training, and methodology of research works in this direction, and we have colleagues that are ready, to help our authors when they need counseling in some situations. So, in Naples, everything is possible to win the championship. And, well, even to make transplants was really something that I would never thought would have been possible. And make a journal, naturally, let's say, a little bit homemade. But all this, I have done to a man who is Professor Henri Bismuth, that I thank. He was on my way to Damascus in 1985 and then 1989, and I understood which could be my future. And okay, don't worry, this is not the Last Supper, but is the master with ourselves, and because he has his hands. This is the picture I prefer more than the Leonardo da Vinci over here, because, there is someone, and his hands has taught me all what I have learned. Thank you, Henri.
we have the first discussion, Professor Clavier, that is commenting this very nice. You did more transplant than the Italian championship anyway, yeah?
Yeah, Fulvio, congratulations. I think you did everything right here when I look at that. I just remember when I arrived in Switzerland now 20 years ago, we went also through the same thinking. There was Acta Helvetica Chirurgica, where there was some case report in German, in Italian, etc., with a huge discussion what to do, and then country small, and we linked, in fact, with the BGS at that time, because it was necessary to have a link. I mean, yeah, I really congratulate, I admire. The first things I think that you were very smart is the name of the journal. Right? You could have called Italian Journal of Surgery, or I don't know, and the update in surgery looks really international. I mean, you know, and who signed that? The American, this is JAMA, is also American in some way. So I think you have the right to have your journal, and at the end of the day, the only thing that will count is the quality and the leadership on that. So I think it was a very smart move to start with this. You got the impact factors. There's obviously a thinking in terms of developing this. You have some good paper. And you are in the game. I think people who want to publish an impact factor of 2.7, I think, as you say, is the same as probably surgery, Langenbeck, etc. So you are now in this league of this journal. Many of these impact factors, as you know, are manipulated highway. I mean, I would not cite journal, but top journal, that's the only topic that they have is how they can increase the impact factor, meaning be cited very early, the first 2 years. And there's strong evidence that show that paper are cited only 3-4 years after are the best paper, because it takes time for the people to accept, they are disruptive, etc. They go. So there is anyway some misleading effect on the misleading marker on the quality. But really, I'm amazed. I think it's absolutely fantastic. It's also international. I don't know how many papers do you have outside of Italy that are published in this journal. Do you have a percent? How many?
Yeah.
Maybe show the data.
Outside of Italy,
yeah,
more than 80%.
80% come from outside, so that's a huge marker also of success, right? They're coming because it's a good journal, because it's updates in surgery. I think the name is certainly appealing. Well, it play a role, and I think that's you have look at everything. I mean, the editorial board, and also the idea to go in territories that are not particularly well covered by others, like you say, education, which is training, all that's important. This is not extremely well cited today. That's what many journals are a bit restrictive, but to be persistent, because that's also the future. With the robot or whatever, I think there will be more and more interest in describing training and metric of training, etc. So just I can only congratulate. I don't have many questions, because I think you've done everything right. So congratulations, for sure.
Thank you.
And as Italian, I cannot avoid also to congratulate.
No. Congratulations by Pierre Clavier, it's enough for me.
Of course, but you know, I am the chairman, I have to conclude. So I will pass the moderation to my friend René.
Okay, the second communication is by Pietro Majno. A new simple tool to improve the relationship between the doctor and the patient, and the discussant will be Fulvio after. Thank you, Pietro.
Right, I'm happy to be here, of course, in my hometown, but also happy to have given you a talk on simplicity 2 years ago. And simplicity is not only and always simple. And of course, I owe a lot of this talk, in fact, to my wife, because this went, and is the main acknowledgement, the background work for this is very long indeed, and it's lots of family discussions, but you will see how it develops. We know that stories are extremely important. Each of us has a personal story, and that constitutes our identity. But also stories build the identity of families and groups. And we are a group, as we see here from Henri, very built around our stories and our identities. La prostituée de New York, other stories really make up our group. In fact, our brain is wired to give an inordinate importance to stories, more than facts and numbers. And we've seen recently the Titanic submarine sinking 5 people, more important in the papers than the 500 they have no history. Impressive. And our brain is done like that. And in the literature, there are plenty of examples of how important stories are for us. I could have picked 5, 6 main authors, but the one really, for me, made the difference is Primo Levi. Primo Levi exemplified how we are our histories. On the basis of that, we decided in Lugano to undergo an experiment. At the end of the outpatient visit, when we first meet the patient, to take him in charge of major surgery, not just trifling surgery, but major surgery, we say, by the way, we are doing a study and learning how knowing each other better could improve our relationship. And we put a lot of attention into the letter that we give physically to the patient. It should be short, and then it has 6 points that in this short letter are embedded. The first one is the clear aim. We want to improve our relationship with you. You matter to us. The second, that we are still learning. We are doing this as a step-up learning process. It should have structure. One open question, you introduce yourself as you want, but also tell us what's important for you and what's important for us to know, to treat you while you are in hospital as a patient and not just as a person and not just as a patient. Then we wanted to make it inclusive. You can type, most patients do now, or the family does for them, but you can also write, handwrite, or you can also tell the story. We'll give you a secretary that you can recount your story to her. We should be explicit about the people who will read this biography, and we decided that everybody who sees the patient at least once can read it and should read it. And the last thing that we added is that we should give it a form of reciprocity. We ask you to introduce yourself, but we give you something that will allow you to know us a little bit better. We anticipated that the project would be welcomed by patients and families, welcomed by all the doctors and nurses that would treat with the patient, that would improve the relationship with the patient, and would improve the patient's experience. Now we are quite a bit of time along the line. We analyzed, and I present you the analysis of the first 60 biographies, and indeed the acceptance was extremely high. We had only one patient who refused. I don't know why he refused. He didn't want to tell me, but he refused. But otherwise, absolutely exceptional. Very welcome by everybody who reads the biography. They're really interested to know who the patient is. We believe, and I will show you how, that this has improved quite intensely our relationship with the patient. But has it improved the patient's experience? Are they happier than they would be before? And for that, we have planned a randomized trial. We applied for a National Foundation grant to study this, whether it's improved or not. We can discuss how the study is engineered, because it was not easy, because we believe that by doing this, in fact, we change as well as our patients. So the methodology is, in fact, quite difficult. But we could do a qualitative study. I mean, Olivier Farge and Compagnons told us about qualitative research. By and large, I will show you what it is. It's an interesting approach. On the roots of it are in narrative medicine. And it can, in fact, extract a lot of information simply by going to depth of the biographies. There were some preliminary steps. The ethics committee, and I think this was important, allowed us to study the biographies, provided they were anonymized, without going back to the patient saying, can we do a qualitative analysis on them? So we had access to that. We anonymized and translated all biographies with DeepL, artificial intelligence. We wanted to avoid a bias by us translating the biographies. And we trusted them to 3 experts in narrative medicine. one in the context of a PhD study, Marta Fadda, who does a PhD supervised by Martha Montello, who's an authority on narrative medicine, a professor of literary medicine in Harvard, and Samia, of course. And they did the qualitative analysis they wanted on the biographies. And they analyzed, you can read it here extensively in their language, what they wanted to learn and tell us from those biographies. But this is a work they did. We did not do the work. They did the work. And they analyzed these biographies in depth to extract the main themes that would come up in the biographies. And a lot of work, a lot of depth, very well supervised by Professor Montello. And the main results are here. They saturated the content of the analysis after 8 biographies only. This is a result in itself. The themes of the patients were so strong and important that all the patients said, expressed the same concerns quite uniformly. The concerns were mainly the 3 ones I listed here: the plea to be known and to be seen as a unique person. They wanted to engage with us with these biographies. And the last one, a quest of protection. They felt their identity threatened by coming into hospital, to be anonymized, and they identified us as the guardians of their identities. Very strong feeling that they had. I quote you a few examples of this. The plea to be known. They went into lots of details to express the unique nature. Some of them relevant, some of them irrelevant, but this came out very strongly. And indeed, they are unique. Their needs, they express very clearly, are different. Some of them want to be addressed by their family name. Some of them want to be addressed by their first name and two, and they see the addressing as a family name as a sign of distance that they don't want to go with. Some want lots of explaining, some want very little explaining, and they're very clearly in explaining that. They want to engage with us, and by revealing some intimate details, they really want to bond with the team. You can read the sentences. I don't think I have to read them for you. And the last was a quest for protection. They feel threatened by coming into hospital, and they feel that their identity is really put into jeopardy by the experience of the hospitalization. Additional thoughts, and these are the last 3 slides. We believe that experience has changed us profoundly. For once, I started a difference. I saw a difference between patients coming in as an emergency and patients coming in through the outpatient clinic. I made this biography experiment with patients coming in the clinic, as Alessandra did, but the emergency, they did not have that chance. And I saw a gradient developing in the relationship I had with the patients with the clinic and with emergencies. And now I've started making this appointment for the patient, even if they come up at the emergency department. Then I saw greater attachment to the whole of team. The intensity of the relationship with the patient has changed, not just for me, but for others. More intensity, but no more work. It's the patient who are doing the work. And the relationship of the patient has really changed. And the last thing I want to share with you is, why have I not done it before? Why has nobody done it before? And I was thinking about it, and the answer for that I found in a book by Rita Charon on narrative medicine. And as doctors, we underestimate the difference and the gradient of power that we have between us and our patients. To say it in other words, the risk of anonymity of patients, we don't perceive it. When we come into hospital, we or our family are not a patient. We keep our identity when we go into hospitals. But patients are threatened in a way that we do not understand. And I think this is the reason why we are not aware or not as aware of the threat that patients have to their identity when they come into hospital. And I think this is why, as a doctor, I did not think of it before. And I thank you for your attention.
Thank you so much, Pietro. So the discussant is Fulvio. Oh, no? No? You are the discussant. No, no problem. Don't take care of it.
Well, I can only thank you, Pietro, for this idea that you had. As Professor Bismuth said this morning, the future is in the past, because the personal relationship that we used to have, actually I have, for each patient, I have a handwritten card where I ask many of the things that you do, not so many, not what they expect. And this is one of the problems I'm going to raise to you. But this is what we should do. Maybe we don't do always, starting from me, and have a relationship, a strict relationship with our patient, and know and let them speak. In this case, let them write, but it's okay. I have two questions. The first one we already discussed, but when you present yourself, when you ask the patient to write this letter, and then in the second visit, maybe you are not present. There is a problem, of identifying, saying, okay, you ask me to give a letter, then I don't see you. And that's with all the many things that we have to do during our day. This is a question that probably you should explain to us how to do. And the second question is this helping a medical query, or is against a medical query?
A medical?
Query, a medical contest afterwards. If something goes wrong, how do you say? Yeah. Right? I don't know. Because if you ask the patient, you say what you want to do, how do you want to treat, and then things do not go as we may happen in a complex surgery. This is a problem. At the same time, the fact that he wants to deal with us and to speak and to write his little biography, this could lower the level of context afterwards. I don't know. I'm just asking to you, because in our country, as you know, we have a very high level of problems with medical context. So,
I think it's two important questions. For the first one, it's not me wanting to know them, it's the team. It's the identity of the team is put forward in this letter. In fact, it's signed by Alessandra and me, not just by me. And it is said we will share it to the team, and as soon as the biography comes in, we mail it to everybody in the team. The secretary knows it. The nurse on the floor knows it. The anesthetist. And so everybody knows it. I mean, it can be done for probably few patients, and we restrict it, of course, to patients who come in for major surgery, not just for all surgeries. The litigation question. We did not have any litigation from any of the now about 80 biographies we had. We believe that the quality of the bonding with the patient is, and the confidence, we saw that we cannot demonstrate it here. They express confidence in the biographies, but we don't see them now, and we should study them after 6 months, which we have not done. So for, at the moment, it's still a very anecdotal and impression kind of feeling, but the feeling that we have is that the confidence from our patient to us has increased dramatically.
Okay. Question, comment? Yes, Mr. Bismuth.
Of course, it is original. I appreciate a lot, and this is really very important. Only I would like to do something. It could be, you remind this, but many years ago, I transplant a psychologist. And she told me after the operation, the suffering she had in the intensive care unit, when apparently she was in the coma, but she was listening everything. And she had the feeling to be considered as a thing, not the people. People were speaking about her as she was nothing. And she complained about that, and you know what we did, and she proposed. We did an association of psychologists in intensive care, which is always existing, organizing congress and spreading not only from Paul Brousse, but all the other hospitals, not only in Paris, but in France. This is one point. Second point is that the nurses knows better the patient than us. It could be the resident, it could be all the people around. So my question is this. One, you have the written autobiography that give what the patient wants to write. Could be is not totally his own personality. Or, but it is difficult to do it, if we have staff meetings for the medical story of the patient. Ideally, we may have staff meeting for the personality of the patient. Of course, it is not possible. We have no time to do that. To discuss with the nurse, with the anesthetist, with everything around the patient, a kind of multidisciplinarity, identity or biography of the patient, take a better of him. So my question is, do you think it could be different? The result could be different, what say the patient and what we perceive from the patient. Do you think it is a different?
Alessandra, have we seen a difference between what the patient tell us and what we feel they are? And in fact, the gap, if this is a question, the gap between what they tell us and what we feel they are, in general, it's so little compared to what we knew before. Before, we simply did not know them. We did not know what they expected. We did not know what they were, and also we did not know how important for them was to introduce themselves to us. This was grossly under-evaluated, and there is a liberation there is happiness, I would say, of the patients. It's great that you ask to introduce myself.
I would add that even if the patient say very little, even a few words say a lot of this person, even if they don't describe very much of themselves, you can always catch
and you catch so much more, even 10 lines. Patients have written 10 lines. The shortest is 10 lines, the longest is 5 pages. Yeah, so, but it's rare. The majority is 1 page. And it saves you so much work for the quality it gives you. Yeah.
Pietro.
Yes. Dimitri?
Pietro, this is really excellent. I just have a question. Did you study, and if you did, have you noticed any differences in terms of overall experience, everything combined, based on the patient's different ethnic, cultural, or primary language background?
In fact, no. It doesn't change. I mean, we work in a fairly mixed bag with a fairly mixed pool of patients. Many immigrants, many Swiss. The reaction of the patients of increasing the trust they have in you is uniform.
Pietro, fantastic work. Thank you very much. I put a lot of importance in the relationship between patients and doctor. But one question, you go in the intimacy of the patients, and you might have...
No, I don't. They do.
They do, yes,
yeah.
They do. Okay, but it will have an implication on you, and you might have an affective relationship, let's say, you see the patient differently. Quelques-uns sont sympas, d'autres sont pas sympas, to make it simple. Yeah. And do you think that this might change your decisions, your medical decisions, in if you have complications, for example, or you go further with some patients and not with others?
Whether this bonding pushes me to do things I shouldn't be doing. Yeah, this. Well, we go very far in what we do for our patients in general. I mean, our group. So it's no difference, in fact.
Could it influence your...
I don't know, but maybe we should study it. I mean, we can discuss about the design of the trial that we want to do. But it would take too much time. We can discuss it later. But in fact, when you ask your question, have I ever been embarrassed by a biography that the patient sent to us? And so far, no. I mean, they know that the biography will be spread, so they will not tell you things that they don't want to be read or known by others. And we don't pull information from them. We ask them to volunteer them, which is part of the success of the story, I think.
Eduardo?
I was a little bit surprised, but what is the intention to do that kind of approach? I am obsessed by the non-technical skills in surgery. You know, I think that's one of the things that Compagnons Hepatobiliaires must also look intensively. This aspect of how can you teach compassion to a surgeon? You know, there are things that you can't teach. You only can teach by example. But okay, why? To do that is to better treat the patient. What is the intention to do?
I think, but I cannot prove it yet. I think that patients have a better experience of their relationship with the team, and also it is one of you are. It's one of the things that sort of puzzled me. You were shaking your hands along the presentation. Tell me, Laurence, what you think.
Well.
But this is one of the things that really struck me.
I'm also surprised. I don't understand why you want to standardize. Because, in fact, for me, you have this information. When you talk to your patient 5 minutes, he wants to tell you something, he can. He doesn't want. I think it's intrusive. Let me finish. Professor Bismuth said, the shocking point for me is that the autobiography is diffused to the nurse, to all the team. And I think that the patient has to, in front of the surgeon, he wants to be at his advantage. He will see an autobiography which will perhaps not be real. But he will speak to the nurse differently. And the point for me is that the nurse and the surgeon is a team. They discuss between us. So for me, this autobiography, these demands, is not useful for me if you speak to the patient, to look to your patient, whatever the surgeon. You said a heavy surgeon, no. Even a hernia, it's important for them. So for me, it's not depending on the procedure. It's depending on what you will tell him or her when you see him. And the relationship, you put this allow a better attachment to the team. But this is not the purpose. The purpose is that the patient has a good impression of the hospitalization and of his, and mainly, and forget after, because it's an hospitalization, an operation is a bad experience. So we have not to seek for attachment. We have to seek for a good management, and after the patient, well, doesn't think about that. So for me,
very interesting.
All that, I don't understand. It's too, well, it's too standardized. Each patient is different, and you can't ask them to do an autobiography. You ask me if I come to you, and you ask me to do that, and I will be the person who refuse.
Yes, but you have. But you are.
Yes. Okay.
Empathy.
I think.
Empathy. Empathy is, I think, the most important quality of a doctor. If you are not empathy, you cannot be a doctor.
John has also a question. I think we should shorten. It's a fantastic, exciting, I would say, field, but
I'll keep it very short. Similar to what Valerio said, I think this could have the potential to alter behavior of your staff. I've trained many surgeons in my career, and a certain cohort of them naturally develop a great affinity for patients. And I've noticed that when something goes wrong, you have a mortality, this type of surgeon, feels crushed. He has a major grief reaction and sometimes finds it very difficult to cope. And my advice to them, I cannot advise them to be uncaring, of course, and I don't want them to be so heavily invested and attached to their patients that every mortality becomes a major, impact on their career. You must have a happy medium. So my question to you, Pietro, and this is amazing that you thought of doing this, but my question to you is, are you storing up problems for your staff by putting in a structural system where you'll have a deep relationship with your patients? And will this cause a problem to your staff?
Yeah, I'll ask the staff. Alessandra, raise up and speak loud.
I think in my humble experience, this project has only improved my feelings and the way I cure the patients. For sure, it puts you on another level with the patient, so sometimes, you're right, it can be quite hard to bear a difficult situation, but I think this is a plus, not a minus. Yes.
Last, Pierre-Alain.
Well, I mean, it's fascinating. You can see this out-of-the-box topic. It's emotional. I wonder if there is not another mechanism here. We are doing now with slowly a painting therapy in patients with cancer and surgery, with very interesting data suggesting that you need a third of the pain medication after, etc. Meaning the patient is not the relationship, it's the patient being able, to get out everything, to express his anxiety, this patient with cancer. And I was amazed because I thought that was a little bit guru stuff. It's incredibly effective in patient, and these randomized trials, some are not, so it's a very difficult randomization because there's a bias. but I've become absolutely convinced, and we are not involved in terms of knowing all the secret of the patient, but they get out all their anxiety, etc., and they go and approach the surgery in a very different way. And I wonder if that's not also one of the mechanisms, just to be able to put from, I think painting is probably even more effective, because that's the first things we do when we come in this world, but it could be one mechanism to get it, I don't know.
What Martha Montello described, an American, and she said patients were bursting of desire to introduce themselves.
So very, very exciting field. Many, many thanks, Pietro.
Then I introduce Oscar Traynor, that he will give us a lecture on why use yesterday training for tomorrow's surgeon. It's, I guess, a equally amazing argument to be discussed.
Good title.
Yes, very nice.
So, Monsieur Bismuth, chers compagnons, it is a great pleasure to be here at this year's reunion in Milan. I think I'm probably the longest serving member of this group. I was initiated into the Compagnon in 1988, along with my good friend Miguel Ciardulo, who sadly has passed away. So I've been 35 years in this group, and I'm delighted to have an opportunity to talk today about one of the very few subjects that I still know anything about, which is the training of future surgeons. Surgery is different to most other medical specialties in as much as it is at the same time a science, a craft, and an art. The science is the knowledge and judgment that we need in order to safely take care of our patients. The craft is the technical skill that we need in order to actually perform surgical procedures. And the art is the non-technical skill, or human factors, that are increasingly important in order to allow us to function effectively as part of a modern multidisciplinary surgical team. Now, because surgery is science, craft, and art, training in surgery is always going to be more challenging than training in non-craft disciplines like internal medicine or psychiatry. The traditional model of training in surgery is the so-called apprenticeship model that was popularized by the great American surgeon William Halsted towards the end of the 19th century. Now, apprenticeship in surgery is not much different in principle to apprenticeship in any other craft-based discipline, such as carpentry or plumbing or electricity. Essentially, an apprentice or trainee is attached to a master or trainer, and they learn first by watching the master at work, then by doing parts of tasks under supervision, then by doing full tasks under supervision, and then by doing full tasks under progressively less supervision until they are deemed competent to perform these tasks independently. That's what apprenticeship is. That's how it works. In a sense, it is an experiential model of learning, which is often summarized by the aphorism, see one, do one, or teach one. Now, apprenticeship has served us really well in surgical training for well over 100 years. But there are two essential ingredients which are vital for the success of apprenticeship. The first is the opportunity to perform a large volume of repeated practice, and that involves working long hours over many years. The second is the relationship that develops between the trainer and the trainee, a relationship in which the trainer, in a very real sense, becomes a role model for the trainee, so that the trainee can gradually assimilate the professional values and attitudes and behaviors of the trainer. And without those two vital ingredients, apprenticeship simply cannot work. Over the last 15 years, we have seen significant challenges for this traditional apprenticeship model of learning. Firstly, around the world, there are pressures to reduce the duration of surgical training and to make it more streamlined and more efficient. It is becoming increasingly difficult to explain to the public, and particularly to explain to those who pay for surgical training, why it should take 12 to 14 years to train a surgeon. To put this into perspective, NASA can train an astronaut in 3 years. In 3 years, they can take an ordinary human being and turn them into someone who can take a multi-billion-dollar spacecraft into space, perform weeks or even months of complex tasks in space, and bring that spacecraft back to Earth again. 3 years. And you know what? That actually is rocket science. So not only are we under pressure to reduce the duration of training, we also have a reduced number of hours worked per week. So since the introduction of the European Working Time Directive and other similar directives around the world, trainees are now working significantly fewer hours in every week of training than they were 15 or 20 years ago. But that impacts significantly on those two vital ingredients that I just spoke about: the opportunity to engage in a large volume of repeated practice and the fundamentally important relationship between trainer and trainee. But there's more. We know that there's an ever-increasing use of technology in surgical practice, like robotic surgery and advanced minimally invasive surgery, which make it very difficult for trainees, particularly junior trainees, to actually perform the surgical procedures. There's an ever-increasing focus on reaching service targets, which means that there's decreased time for training. Certainly in my country and in the United Kingdom, we regularly see cancellation of elective surgery because of pressures on the emergency beds. And there are changing public expectations. The public no longer wish to be used as training material, and instead they want their surgery to be performed by the most senior and experienced member of the surgical team, which is precisely what I would want. So for all of these reasons, the traditional apprenticeship model of surgical training, which has served us so well for over 100 years, is currently on life support and is in imminent risk of demise. And we urgently need to devise a new model of surgical training for the future. So how would we even go about that? How can we devise a new model of surgical training for the next generation of surgeons? Well, a good starting point might be to look at how other high-risk industries, like the nuclear power industry, the oil industry, military defense forces, how they train their people, and particularly how they train their people for mission-critical high-risk situations and tasks. And what these industries have in common is that they have a very clear definition of the competencies that they expect at the end of training, and they train people to competence. People are deemed to have finished training when they reach those competencies, rather than by the passage of an arbitrary period of time. Now, if we're going to change to a competency-based system of education and training, then we must have a robust system for verification and documentation of competence. So for the remainder of my talk this evening, I want to focus on 3 areas. Firstly, this whole concept of verification and documentation of competence. Secondly, how we implement next-generation learning technologies into our surgical training curriculum. And thirdly, the whole area of professionalization of training. Training starts with the curriculum. In Ireland and in the United Kingdom, we have a common curriculum which is agreed between the 4 surgical royal colleges in the United Kingdom and Ireland, the Intercollegiate Surgical Curriculum Programme, and it is a curriculum which exists for all 10 surgical specialties. There's a common format for the curriculum for every specialty, and it defines the structure of training and, most importantly, the outcomes that are expected at the end of training. It defines what will be learned, the syllabus, how it will be taught, the pedagogy, and very importantly, how it will be assessed, the assessment framework. And finally, it defines the role of the trainers and their responsibilities. At the heart of verification and documentation of competence is assessment. Assessment and the assessment framework is what underpins the whole process of verification and documentation of competence. Now, many of you will have been in Dublin for the Compagnon meeting in 2017 and will have seen our simulation centre at the Royal College of Surgeons in Ireland. In fact, the Compagnon will go down in history in RCSI as the very first official visitors to our new simulation centre when it opened in June 2017. You were actually the first visitors to this centre. Well, I can tell you it has become an extremely busy centre since then, and all of our surgical trainees in Ireland come to the college for simulation-based training days, 6 days every year. So we have about 520 surgical trainees in Ireland across all of the surgical specialties. And every one of them comes to our simulation centre on 6 separate occasions during the year for intensive simulation-based surgical training. And that happens using experienced surgical trainers with a high tutor-to-trainee ratio. But the trainees love it. They love playing with the virtual reality simulators, but it's not about playing with the toys. There are very clearly defined learning objectives for every day that they come, and they must meet those learning objectives in order to progress to the next stage of their syllabus and curriculum. Everything that happens in the simulation day is recorded. As you can see here with the arrows, there are 2 video cameras, a minimum of 2 video cameras above every skill station. And everything that happens during the training day is recorded, and the trainees themselves can access the recordings of their own performance afterwards on their iPhone. They can log on through their phone and get access to their recordings of what they did, and most importantly, to recordings of the feedback that they got from the trainers during the day. Now, recently we've launched the RCSI Surgical Skills Platform. So we've begun to realize that a lot of the basic surgical skills that we teach don't need the resources of a very elaborate and expensive simulation center such as the one that I've just shown you. There are basic surgical skills that every surgeon needs in order to perform surgical operations, such as knot tying and suturing and anastomosis and tendon repair, cystic duct ligation. These are basic skills that don't require elaborate simulation facilities. And so we've designed this platform which trainees can have at home. It's a fairly basic platform. In the center of the platform, they can put the model that they're going to work with. And then, as you can see here, mounted on this rotatable wheel, there is a high-definition video camera with a high-quality LED light to illuminate what they're doing. And on the wheel, the camera can rotate either clockwise or anti-clockwise so that they can get any angle they need for the skills performance. So everything that they do is recorded on this high-definition video camera. Now, video-based assessment, or VBA, is a hot topic in surgical education at the moment. Every surgical meeting you go to, there's a lot of talk about video-based assessment. But in a sense, it's a little bit like the emperor's new clothes, because everyone is saying how great video-based assessment is. This is the future of surgical education. But nobody is asking the obvious question, who is going to look at and analyze all these videos? Because to be perfectly honest, watching somebody else's surgical videos is just marginally more interesting than watching a complete stranger's wedding video. It's just not going to happen. And so for that reason, one of our research fellows in RCSI at the moment is doing his PhD on the use or potential use of artificial intelligence to perform computer-based task analysis of the skills that the trainee performs on their platform, so that they can generate an objective score based on meaningful criteria and give useful feedback to the trainee on their performance and on areas where they need to improve. Now, of course, you cannot become a good surgeon in the skills center, just as you cannot become a good golfer on the driving range. But as we see it, the skills laboratory is where trainees should learn the basic skills. And they do this through demonstration by senior experienced faculty. Then they practice, then they get feedback, and then they get coaching. And they stay in this loop of demonstration, practice, feedback, and coaching until they are ready for assessment and documentation of proficiency. And in our college, we have an annual skills assessment for all of our surgical trainees. So they all come in for a 7th day each year for a skills assessment. And these are high stakes assessments. By this, I mean that they do actually count towards career progression. If they don't pass their skill stations, they cannot progress to the next stage of their surgical training. Whilst they learn their basic skills in the skills laboratory, they develop their skills in the hospital, in the workplace. And they do this firstly by practice under observation, then documentation of capability, and then they gradually begin to accumulate experience, achieve competence, and eventually, hopefully, achieve expertise or mastery. And during their work in the hospital, they also undergo assessments. Our trainees are assessed to within an inch of their lives. So every time they become competent in a particular procedure, they then have to be signed off by a procedure-based assessment, where they perform the procedure under the supervision of their training supervisor, and there's an objective checklist where they can be scored and either pass or fail. But they also have an electronic logbook, which we have designed ourselves in RCSI. It's a purpose-designed logbook for our trainees. And it looks not just at the number of cases that trainees have performed, but also shows the dashboard giving the indicative numbers of index surgical procedures. So for every specialty, like neurosurgery, orthopedics, urology, for every specialty, we've defined 12 to 15 index surgical procedures for that specialty. That is the core or essential procedures for that specialty. And then we've asked the specialties to decide and define an indicative number that they would expect a trainee to have performed independently at the end of training. And so there's a dashboard that shows what percentage of the indicative number the trainee has already achieved. So we can see at a glance, the trainees can see themselves at a glance, how they are proceeding with their dashboard of index procedures. But more importantly, we can see. I can take out my mobile phone now, and in 30 seconds, I can log on to all of the trainees in Ireland, and I can see how any one of the trainees is progressing in relation to the indicative number of index surgical procedures. But it's not just about operative technical skills. We also simulate all the other activities that a surgeon is engaged in during the course of their work as surgeons in the hospital. So we have simulated ward rounds using simulated patients. We have a bank of about 65 members of the public who have volunteered to become simulated patients and are specifically trained for that purpose. And they come in and they participate in these simulated ward rounds, which focus on preoperative care, postoperative care, multidisciplinary team working, but most importantly, there's a focus on early recognition of the deteriorating patient. All of the patient safety literature emphasizes the fact that failure to rescue is often linked to untimely failure to recognize a deteriorating patient, not recognizing it in time, not taking appropriate action in time. We also do simulated nights on call, again, using our simulated patients, or in some cases using mannequins, as shown here. This is obviously not a real wound. This is done by one of our simulation technicians. In about 20 minutes, they can make up one of these complex wounds using silicone and theatrical paints. They're very realistic, and they are a very realistic experience for the trainees. Now, I'd like to talk a little bit about the use of next-generation learning technologies, such as virtual reality. We are very much committed to the use of the next-generation learning technologies in training for our future surgeons. This is an example of a virtual reality program that we developed in-house for the management of a complex chest trauma scenario. So when the trainee puts on their headgear, it takes them in a stepwise fashion through the entire scenario, from the arrival of the patient in the emergency department, through to the initial assessment, resuscitation, investigation, and eventually placement of chest drain for a complex tension pneumothorax. We also use augmented reality. So this is an example of a neurosurgery course that we ran a number of months ago, and we used very simple models. This is just a foam model, and embedded within the foam is a grape, which is a tumor inside a brain. And the trainee, as you can see, is using the CUSA or Cavitron to dissect out the tumor from the brain. But it's not very realistic. And so you see the QR code here. That acts as a fiduciary, and it's picked up by the mobile phone here, and it converts this very, very basic image into a much more realistic image with drapes, retractors, and then there's the brain and the dissection of the tumor. And just around the corner is the metaverse. Avatars, holograms, undoubtedly these are going to have an important role in the future surgical training. To be honest, I think that avatars are going to be more useful in the training of non-technical skills for surgeons rather than the operative technical skills. Non-technical skills such as the way we interact with patients to explain a diagnosis, breaking bad news, getting informed consent, open disclosure, many of the other non-technical skills which are an essential part of our work as surgeons. Some of you may have seen the Apple Vision Pro, which was launched just 2 weeks ago in New York. This is widely believed to be a game changer for virtual reality, pretty much in the same way as the iPhone was a game changer for mobile phones back in 2007. Finally, I want to just say a few words about the whole area of professionalization of training. For more than 100 years, training was something that was done on a voluntary basis by all consultant surgeons as part of their daily work. And that's fine, except that not all surgeons are good trainers. And if we want to get serious about improving the quality of surgical training in the future, we're going to have to give our surgical trainers the skills that they need in order to be effective and competent surgical trainers. And so we've developed a range, a suite of training interventions for trainers in order to make them better trainers in the workplace. And this starts with a very basic one-day course, a Training the Trainer course, which all of our trainees do at the end of training, in their last year of training before they become consultants. Then we have specified purpose short courses like how to examine in the MRCS exam or the FRCS exam, how to perform interviews effectively. Then we have a slightly longer clinicians as educators module. And then some trainers may opt to go on and do a postgraduate certificate or a postgraduate diploma in surgical education. And a very small minority may decide to go all the way to actually get a master's in surgical education. So to summarize, to improve the quality of surgical education and training for the future, we need to be very clear and explicit about defining the competencies that we expect surgeons to have at the end of training. We do need to integrate simulation into the curriculum for surgical training. We need to have a system of training where progression is based on the achievement of competencies. We need to employ the next generation learning technologies. And we need to seriously look at professionalization of the training process. So why would we use yesterday's training for tomorrow's surgeons? I really don't know. Thank you.
Tina, please.
By a strange coincidence, I think we're sharing half of the slides together, so you will see a lot of those. And I really appreciated to have visited your center, but I have a slight difference of option, because you said, why should we use yesterday's training for tomorrow? You described the profession of surgery with 3 tasks. You said you have craft, you have science, and then you have art. Yeah. Art does not exist anymore with this training. My question to you is, when you do the virtual training, and I've tried it, I had the impression that the sensors and the headset, you can't wear it more than 2 hours because there is a risk of epilepsy. So that's number one, and that's from the scientist who said that. So I don't know how long you put the training per se to operate virtually every day for a young trainee. My second question is, once they will become a very excellent technician, in my impression, with that training, and I have the feeling that I will use this as a benchmark. But to train a surgeon, where do you put the part of a mentor, and how do you teach them how to think and to create? Because I don't see that part of innovation exist in the new system. Unfortunately, this is new. We all have to go through it. So I don't know, how do you answer to that?
Okay, well, thank you very much, Gina, for that, those queries. I fundamentally disagree that the art does not exist anymore. I think the art of surgery is probably more important than it has ever been in the past. In the past, the surgical team in the past was largely the surgeon, the anesthetist, the nurses, and that was the team. And there was a very steep hierarchy. The surgeon was very much at the pinnacle of that hierarchical structure. Everybody knew who was the boss. And when the surgeon said, do this, everybody did this. Today's healthcare team is quite different. Today's healthcare team is a multidisciplinary, multi-professional team, and the surgeon is an important member of the team, but the hierarchical system is much flatter than it was 20 or 30 years ago. And we all, as surgeons, have to be able to function effectively as part of that multidisciplinary team. So I would say to you that the personal skills, the human factors, are more important today than they have ever been in the past. And I think that this is a really important part of the training of our future surgeons. Our future surgeons have to be able to function effectively as part of a multidisciplinary, multi-professional team. Now, I've forgotten your next question. Yeah, and that is a real challenge, you know, because surgical trainees work a lot fewer hours than they did, and so their contact time with the trainer is much less than it was 20 years ago, much less. And so how can a trainer be a role model if the trainer never is in contact with the trainee? This is a real challenge, and I do not have the answer to that.
Great talk. Really, I appreciate the tour de force in convincing us, or trying to convince us, that we can format, because it looks like formatting to me, surgeons, and I'm very concerned by that. In fact, I have an app on my phone that I was forced to download, where I evaluate my fellows after each liver section. So it looks like there is now an interface between me and my trainees with the new technology, and I'm playing with this app, and I have to dictate a comment about how the fellow did the case, etc. And then, in fact, I'm being used also because the educators, the professional in education, are using my reports to publish on this. So what I see here is that a new generation of surgeon, and I'm afraid, new generation of surgeon checking boxes. We check boxes. And when we have checked all the boxes, it feels like you're reaching the stage of being an Eagle Scout. You know, it's like having all the badges covered. And certainly there are a lot of trainees which will do very well with this. But they'll do very well with just automated, repeated functions. And what is lost in this, in fact, is the training, at least as I had it, in the United States, where the second-year resident trains the first year, where the third year trains, etc. So it's not only top-down, but it's between themselves. So I think, you know, it's maybe a little bit reductive to put, you know, the trainees within this box. On the other hand, I think there are a lot of potentials for training for our young trainees in a world of global surgery, where they can go elsewhere. There are a lot of places in the world where there's need for trainees and in a good environment. And I think, you know, we tend to look at ourselves with our technology and not look at the world of global surgery and how we can train these, because these young trainees are very interested also in these experiences and in learning, and I think there's no shortage of patients for good training in good condition.
Yeah, they're very, very interesting points. I think you're absolutely right. One of the big risks with checklists for operative procedures is that it becomes a tick box exercise. And certainly we're very conscious of that. I think in the UK and Ireland, it would be fair to say that there's a slight shift in the opposite direction again now. The pendulum is beginning to swing back away from checklists and more towards a holistic overview of trainee performance. So the newest version of the intercollegiate curriculum, which I spoke about, you know, it's more of a holistic overview of performance rather than checklists and tick boxes. So I do agree with you on that. It's something that we need to be aware of. I think you're absolutely right. It's important that other residents on the team participate in teaching the junior people. But I'm sure you're aware that in the United States, there have been many papers in the last couple of years about the lack of preparedness of residents on completion of their 5-year residency program, the lack of preparedness for autonomous independent practice. This is a real worry in the United States, but elsewhere as well. It's a big problem.
Joe?
Yeah, I just have a quick comment. You know, maybe I'm getting old, but you know, you have virtual reality, right? Gina's going to talk about it. And we've forgotten about reality. And what I mean by that is, if you, I don't know how it is in Europe, but you know, you read notes in the States with the EMRs, and if you read the note from the first day of the patient's visit to the last day, it's a billing sheet. It's a redundant, repetitive, it's cut and paste, issue 1. More importantly, and I all due respect, I've seen your center, it's beautiful. I think we've forgotten that, and when a resident calls me, and I say, if you're at the computer, when you're giving me the information, call me back when you're breathing the same air as the patient in their room. And what do I mean by that? All this is wonderful. We have computers, and we're all love it, it's wonderful. But what is the color of the drain? What does it look like? What does the patient smell like? Are you touching their hand? Are you feeling their pulse yourself? This is slowly and rapidly being dissociated from our treatment of the patients. And I love this, it's wonderful, and it looks great on TV, and you could sell it to insurance companies. In all due respect, we are getting away from treating the human. And I'm not against this, but you need to incorporate, like what Pietro has done. He's making an effort to incorporate you know, the human side that we have completely abandoned. So wonderful, yes, no, but the residents now have no idea what the patient looks like, what they smell like, what the drains look like. Has there been a change? Has there granulation on the wound? It's not in the computer. It's not in your metrics.
You are absolutely right. And I think we probably would all agree that the traditional apprenticeship model, where trainees worked 80 to 100 hours a week over 10 or 12 years, produced very fine surgeons who looked after patients very well. Unfortunately, that train has left the station. It's not coming back our way again. No, absolutely not. We are going to find alternative ways of achieving the same result. But that train is not coming back our way again.
Okay, thank you. We have already canceled 3 questions. So it's a pity because it's a very exciting, and also by my side, yes. But we have 2 more.
The last talk was the conventional talk, I would say, before the face-to-face, is done by Gina Crisat about artificial intelligence and liver surgery, a true revolution. And then Simone Famularo will be the discussant.
And actually, it's going to be a sort of continuity with Oscar's talk, because I think the subject is very important, and it's true that sometimes we have to think about reality. So first of all, as usual, I'd like to pay a tribute for our last companion. That used to be the talk of Gilles Manta's talk. So that was Richard Nakache, Gilles Manta, Miguel Sardulo, Lorenzo Capussotti, and Castro de Souza. So why did I choose this subject? Basically, as Oscar said, and there is the push. I mean, I have to say that there is also the push of the new healthcare systems all over the world. They are pushing, and it's true. Why are we waiting? We are lacking doctors, we are lacking surgeons. We should have a surgeon in 3 months, almost. And at the same time, the past 10 years, it's all about artificial intelligence everywhere. And you have an explosion of creation of medtech, medical devices, softwares, and nowadays you can follow your patient with your iPhone. So it is important to see what's the implication on surgery. We know already what's happening in medicine. So basically, we are already medicine 4.0. Past 5 years, you have the genius of IA, Bill Gates, Elon Musk, Jeff Bezos, and of course Sam Altman with the OpenIA and the famous ChatGPT. And it was interesting that they were fighting to each other who's going to win, and they were fighting for the future. And all of a sudden, everything has stopped. Now it's the fear for the future, because even him, Elon Musk, last time when he came to Viva Technology, just a few weeks ago, said we should put a stop in IA and think about regulation. Today, I'm here with you in a scientific meeting, but I was impressed the past 6 months. I've been to meetings where you don't see a lot of physicians. You see quite a few because they know where the business is. But these meetings are having like 1 million people, visitors going into it. And you have the French tech, the med tech, health tech, and you have extraordinary invention in medical device, all based AI, and that's supposed to treat us in the future. Even me, I was lost. So it goes very quickly, and if we don't mastermind this, we're going to be lost really, really quickly. So surgery has evolved. We were with the human era, technology era, and now digital era, as Oscar says, with the glasses. And that led to the concept of virtual reality to augmented reality. This notion came with the comparison with the pilot and the space era, where you have to train and to do simulation. But interestingly, when you speak to the pilot, when you speak to firefighters, when you speak to the army flyers, they tell you that simulation alone is not enough. It has to be coupled with mentoring. So it is important because this is a new age era. It's true that now you have a lot of softwares, and I think that there is a benefit from augmented reality because that allows you to have a virtual surgical planning. I'm sure in France everybody knows the visible patient, and you can have a very good, precise area, what tumor to resect with a minimum risk of having an accident during the operation, or to not to resect entirely the tumor for carcinological reason. So indeed, this concept of virtual reality has increased with the existence of all these new age of glasses and HoloLens and lens, and the last one was the Apple who created it, but you have to go to test it. I don't know how many of you have tested it, but it's absolutely amazing. It's like 360 degrees around you. Your hands are completely in the space, and you bring your organ, you put it on the body. You have the screen in your eyes of the CT scan. You can touch it with this. It's amazing. So it is sci-fi, it's Minority Report, but unless you don't test it, you don't know what you're talking about. So for the planning is good. I have to say that it was interesting to test it, but at the end of the day, keep in your mind that it's a model-based prediction methods, it's a data-driven predictive models, and it's a data-based prediction. So the surgery 4.0, as I say, it is all related to database, and that will be the bad, or I would say the bad critical point for the future. So there we are, textbook surgery. That was what we learned before, and now we went to image-guided surgery because of the machine learning and the e-learning, and all this allow you to overcome the imperfection in surgical training. That will be pleased to ask a trainer. They need to overcome the learning curve of the procedure. It's true that you can learn much more quicker, and it has been proven in some trials, and mainly in the United States, that shows that patient, young trainee who went to simulation were able to do a very quickly a lap appendicectomy rather than someone who had to conventional training. So from this machine learning, we go to this famous artificial intelligence that everybody's talking about. I don't know, but in France, the past 2 or 3 months, if you open the news channel, at one point they speak about ChatGPT, AI, and everybody's starting to have some problem with it, but mostly because of the appearance of the regenerative artificial intelligence. So what is it exactly? Because everybody hear about it, but we don't know how it works. So it's the study of algorithms that gives machine the ability to reason and perform cognitive functions like a human being. So it means that this machine should be able to solve problems, to recognize a word or an object, and to be able to make a decision. So AI in medicine, this field, can be physical, meaning you can have machine like robotic, numerous medical devices, softwares, and it can be virtual. And that will, the aim of it is to be able to have a decision-making strategy for whichever pathology, to make a diagnostic strategy, and to be therapeutic too. So this is a conventional concept of the AI following the Venn diagram. It's a combination of a deep learning process and a machine learning. Machine learning, it's a subtype of AI where the computer program is enabled to learn from data introduced to it and improve with experience, so it's repetition. So the deep learning, it's a subtype of machine learning inspired by the human brain, where the program utilizes architecture that resembles our brain cells, our neurons, and all this has been layered as multiple layers and able to analyze a huge amount of data. You have to be very quickly to learn important terms in AI if you want to follow or if you want to be able to read a scientific paper. So you have the input data. So this is the human who introduced this from a database to the computer, some slides from histopathology, some images from CT and MRI, biomarkers, ultrasound images, and nowadays, because of the electronic health record or medical record, because all this in the computer can extract any word from it to be able to calculate and give you either a decision or either a diagnosis. So this is the input data. This is, let's say, the artificial brain, and this is the prediction. This way of learning, you have the supervised learning and the unsupervised learning. Supervised learning, it means, is the human who give the task to the machine. The unsupervised, it means that the machine is working by itself already with the data that they have. So this is an example of a concept of AI, let's say with a slide of pathology slide. So you show the image to it, you teach the machine to recognize the dot A and B, which is here the meaning of these two dots, nuclei with hyperchromasia and irregular contour. And then you teach the machine that if you have the association of the two, it means cancer. Once you've done that, that's what the AI does, okay? And usually the output of the conclusion, because they have numerous images of slides, 99% usually the machine is right. Another application, but that has not been yet proven, but it's the future, is to utilize AI to try to detect a patient who's going to be, let's say, chemo-resistant to one regimen of chemotherapy. And that's very interesting. There are ongoing trials to do that. So this is the concept. Usually when you have a patient, you treat him with some chemotherapy for, let's say, 4 weeks. Then you're supposed to repeat a CT scan, and whether or not you see if he's responding or not, then you're going to change your line of chemotherapy. AI is to reduce the time and to depict very early and say this patient is not going to respond to chemotherapy. So it means that instead of waiting for 6 weeks, you might change your regimen in 2 weeks because it's likely that this patient is not going to be chemo respondent to that regimen. So that's a trial which is going on. In the past 3 years, really, you have about more than 10,000 papers published in the literature per week. I've tried that in PubMed. So there are a few that you know the application in surgery. I'm sure everybody knows about the surgical safety for lab coli, another that spoke about the situation of artificial intelligence surgery, and focus on disease severity. And then you have multiple journals, and it's very important to try to validate the quality of the publication that you have. You don't know which one are good quality or not. You have to forget everything you learned about evidence-based medicine and how you judge a quality of a paper published with the validation of the methods, the statistics methods. AI have a new concept of evidence-based, and soon you know how to analyze methodologically this paper better. You will understand, because unfortunately, all these publications that concerning our health is published in medical journals written by mathematicians, but very few of the doctors mastermind the word. This is my first headache, okay? So you will see you have another one. So this is to show you an example of a paper application on surgery. So you want to assess the evidence-based recommendation in surgery. They create an algorithm that's called XJ-Boost. Then they evaluate metric. They say accuracy 78%, They use a method of SHAP, and then they do the XAI evaluation. X here, it means a reinforcement, okay? So you have these words, you will find them in every single paper of AI, XAI, explainable AI, SHAP, Shapley additive explanation, SVM, support vector machine, FCN, fully convolutional, sorry about that, neural networks, CAM, class activation mapping, CNN, convolutional neural networks. All these terms you will find in every single paper of AI. So to see what that means, it's going to be very difficult if you don't try to understand. And they use another type of scientific method, or I would say statistical method. So any paper using AI or any trial they want to do, keep in mind that you have to find those words. You have to have a method that describes the supervised learning. You have to have a method, a chapter saying what is the unsupervised learning, and they have to explain to you the neural network algorithm, okay? This is how, if you don't find that, you know it's not a good quality paper. I will give you the reference to see that, because fortunately there is a good scientific method to validate the quality of the paper, and this is published in Nature Research. It's the Consort AI extension. It's open, free labeled, so I advise you to have it, because they explain to you how to assess the paper and its quality. And to have a good example for my talk, I'm going just to focus in 2 articles that I found very useful in G Hepatology of last year, one that used artificial intelligence in hepatocellular carcinoma, and in the other one in liver transplantation, just to show you what are the example, what are the aim, and what they do. But the Consort AI extension, should be your Bible for the future if we are still in the hospitals and working in the medical field. So machine learning, deep learning in liver transplantation, you'll see it's very, very quick. What can be the application? This is an example in application in the pre-transplant setting. The point being that you can assess graft steatosis assessment, you can assess the graft allocation, you can be very predictive to do a good donor-recipient size matching. There are actually 6 current clinical trials going on this field, 2 in France, which are assessing the steatosis of the graft. So this is an example how they use it. So you have the HCC specific recipient parameters. They use it a random forest, clinical data, tumor image. You have the patient parameters, his waiting list, 3, 6, 12 months. Then you have the image of the liver that will be for the graft, for example. They predict the donor steatosis. Then you use your neural calculation, and then you extract what you want from this model. The C here, it's improving donor pathology assessment using the neural network to identify steatosis, and that they might depict that way before DI. Basically, you don't need to do a biopsy on the graft, okay? It will be based on the imaging, it will be based on the parameter of the donor, parameter of the recipient, and then calculation. But you train your machine with previous images so that the machine learn how a steatotic liver looks like. Another example here, it is artificial intelligence for prognostic of HCC. If you look at all the highlight, they just do the prediction of chemoembolization response, if you have a prediction of recurrence of HCC after surgery, using the BCL stage or Milan criteria. So they give you all the example, but unfortunately, all these paper, you don't have enough data. It's not reproducible. So you have a very good quality of paper. They will tell you accuracy 86%, sensitivity 89%, specificity 82%, but it's not reproducible because not everybody is sharing the same data. Every center has his own data, or every country has its own data, so it's not reproducible all over the world. Post-liver transplantation, you can predict a graft failure or rejection, a kidney injury, or a recurrent disease. And this is another example how you can teach your machine with some values. You examine both donor-recipient characteristic, you use the image, you pair with the pathology, and you pair with the clinical data. Then you teach your machine how to depict that so to be able to predict in the future. And at the end of that, it looks like the MELD might change in the future with the AI predictability, which look higher than the conventional MED score. So this is one of the possibility. Another, this is just a resume of, to show you the studies that are going on. I have to say that looking into all these papers, there was only one who achieved a predictive variables. All the other, they couldn't report anything. So it, and only because you have the largest number of patients, 18,000, I mean, almost 19,000 of patients, and they use the registry to be able to test their validity of their model to a huge amount of patients, and they've been able to be a predictive outcome. So after that, after reading all these patients, what you realize is that you have new words, new semantic, new system of validation, and you have a new language. And you, as a physician, it's very difficult to understand all these papers. You don't understand yet the implication. You know how they work, but you don't know what's going to bring you in the future. So it is important that everybody has to understand that you have a standardized way of labeling the data. And that's the whole problem between electronic medical records. You have a type of electronic medical record that you have in the United States. I remember in UK that they have another type of electronic medical record. So if the machine is capable to extract every single word and calculate, you will have different results for the same disease. So standardization is very important to be able to have a similar algorithm. This system of artificial intelligence is here to quantify the surgical performance. And the problem that you face today is none of it. It will be very difficult to have an international database or centers sharing the data because of the privacy. So what is next? On the machine type, to please Hugo, of course, the robotic, for the moment it's controlled by the human, but very soon it's going to be controlled with the AI. One thing for sure, they started to have a complete autonomous part of the robot that can do by itself the anastomosis alone without a human control. But this is where they are heading. And it is the new era. It's called the Smart Tissue Autonomous Robot. And it works, the framework, it's the untrained robot, which is going to be trained via multimodal source of data. I hope I'm not losing you. I know it's very complicated, but believe me, I struggle to read, all these papers. But all this shows you, this is the type of algorithm. This is the same picture that I show you how artificial is working. To have an autonomous robot, you have to use the reinforcement learning that will double train the robot. But in fact, it means that for me, the human is going to train the robot to be autonomous. So we're not going to train trainee, we're going to train robot. So this is where they are heading. So I do not know why. It's, for me, it's just because of the healthcare system has changed, because of the digitalization, there is a complete change of way of thinking. We need to be more performant That's what they are looking for. We need to have a very quick surgeon to be able to operate very quick, and you have to be predictive, because medicine and surgery is going to be very, very, very expensive. When you look at the lens that could cost the 3,000, the robot, all the tools and the medical device, so it's better to predict rather than treat, and that's where the future is going. So that's why they are putting a lot of money into artificial intelligence model algorithm. So this is what I said. It is an algorithm-based strategy. It is decision-making strategy. Yes, indeed, you may have a better patient selection. You may have a better outcome, but we started to be surgeon, mathematician. Now we are automat, and now we shrink. And I think the brain is shrinking, because I was saying earlier, I do not know if we start to think or are we obeying to a machine. This is the worry. And just to recap, and this is a paper that I think I showed it 2 years ago, written by a colorectal surgeon in the United States. All our system is algorithm-based type of surgery, but never forget the one. We're not here to treat numbers, we're here to treat patient. So if a system tells you that this patient does not belong to this algorithm, and it means that I cannot treat it, then it's going to be a problem. I pass on that because it's just and I just want to show you 2 more slides. There was a worry to have a human versus machine learning. It's not something new. It happened already in the 17th century. René Descartes, a mathematician, was the first one to think that a man can be numbered and the thought can be numbered. But Rabelais is the one to say, favor the ethics. And this is what we're living now, that artificial intelligence without regulation, without ethics, is going to be a problem. So I think that it can be useful in the future. It's very important to mastermind the artificial intelligence just to make sure that we don't go too far. Léonard de Vinci says, who thinks little is very wrong. I don't know how our old masters think about artificial intelligence, but I have the impression that
artificial intelligence drives me crazy.
There you are. And my conclusion is this, that intelligence and imagination creates non-artificial companion, and I'm happy to be real and not virtual.
Thank you, Gina. And so the discussant is Simone Famularo.
So congratulations for your speech. I was very surprised, actually, by, let me say, your fear to be a substitute from the robots in the near future. Few months ago, we published a paper where we developed this model that was able to allocate the patients to the best treatment for the hepatocellular carcinoma. One of the first concerns was the application of such a model, no? Because we try to apply this, and for example, if the model was saying the patient should undergo surgery, this doesn't automatically mean that the patient can go to surgery, because there's also the consideration about the technical feasibility that the model is totally unable to provide us. Using the word of the previous speaker, the model is able to provide us somehow the science, but the heart is still in the hand of the surgeons. So my question is somehow, how can we balance the fact that we will use the artificial intelligence in the clinical practice even now, and the need somehow to keep the creativity and in general the imaginific part of our job in the surgical field. What can we do, actually, in your opinion, to manage this problem?
Thank you very much. It will be very quick. What I think that we cannot hide from modern time. So that's what I was insisting and say, we as doctors, we have to know very well what is AI. However, we have to make sure that, keep in mind that the mind, you have to think and be creative. If we are here just to obey to a model, it's just a theory, as they say, tick box policy, and that's not good. So you have to be imaginative and also challenge yourself. I'm not saying no, but I don't say yes to put AI for everything. Thank you.
Thank you. Our algorithm is saying that we are late, and so our non-artificial intelligence is conducting us to shorten the discussion. Okay, and so to a very burning question, John. Okay.
The battle is going to be with surgeons and physicians embracing AI. I'm sure we will embrace it as a tool. My worry is when this technology gets in the hand of the insurance companies and the politicians, then they will have a tool to control us and tell us what needs to be done. That's the biggest thing.
I totally agree. This is my fear. I think it's coming from the healthcare system and the... Yeah.
I have a question to Gina. It's fantastic. I love. In your mind, there will be, in one part, we are the two-phase.
Yeah.
One, in face of patient, we do the diagnosis, and then, as surgeon, we do the technical report. According to what you said, there will be one part, so artificial intelligence, will do the diagnosis. Second part, we know now, the robot will do the surgery. But now you said, of course, there is a human that will control the two-phase, kind of controller. But who will be the controller? Who will train the controller? Oscar.
That's the whole problem.
On the two parts, what could be this controller? There's been somebody better
Yeah.
than the artificial intelligence, better than the robot. Today, we may think about weak, but in the future, we will disappear. And who will control?
Yes, we are disappearing. It's starting already. One.
Okay. You want to give a response, Laurence?
I'm a little depressed. I think we need a lot of alcohol. But for Oscar, I think just Oscar, I want to say something to Oscar. It was amazing because you're completely right. And if you add the two, you're right. It's finished now. It's finished. We are finished. Okay. And there are so many to learn, so little time to learn it. So you are right. We are going to do this simulation program, etc. But I think that we have still some power. For example, what you advise, what you preview, in fact, should be done during the first and second year of residency, for example. Then we have to make them enter into the hospital, into the patient, and artificial intelligence, in fact, because I don't understand exactly, there is two levels. You show HCC, liver transplantation, decision making. Well, this is not for me artificial intelligence. We have score for that, but very complicated. We don't know all the score, and maybe artificial intelligence will be together and then give an answer, and that's us to know what we'll do with this answer. That's our power. But I think that this type of artificial intelligence we already have, okay, and it is facilitating. Another point is the robot, the artificial intelligence replacing completely the surgeon. And, well, that is worrying, but it is probably the future. But I think we have still the power of deciding when we are going to do this simulation program, how we will articulate with the human factor, with hospital, with time at the bed, and then what we will do with artificial intelligence. I don't think it's good to say, wow, this is a danger. This is not danger. It could be a help. So, okay, now alcohol.
We are finished. Yeah.
You know, throughout the entire history of human civilization, nobody has ever been able to hold back or control scientific progress. Scientific progress is a feature of human civilization. It has always been there. It will always be there. We cannot hold it back. It's going to happen.
Okay. It's a good final word, I would say, before introducing the next session with Henri Bismuth will moderate, will be chair of this session with Pierre-Alain Clavien and Hugo Pinto Marques.
I call also the two discussants, Hugo and Pierre. No. You must come here. Assieds-toi là. Non. Non, viens là. Non. Viens ici. Go. Voilà. Yes.
The first talk is the other one.
You, not this one?
No.
This is, yes, but he has to connect his own computer.
This is a very special session. For the first time, the Compagnons are doing that. And really, I don't know at all what we are doing. First, who is speaking first?
Hugo.
Hugo, start.
So we start. We don't have any tea, right?
Yes. 1 minute.
Okay, so again, thank you very much for this opportunity. So we start by speaking about textbook outcomes following HPB surgery. So this session is essentially about the use of speaking about how to control and to know the best measure of outcome after HPB surgery. And in fact, when we think about the usual measures of outcome, single measures of outcome, such as mortality or complications, we know increasingly that using composite measures of outcome is a better way of measuring the outcome. And we learned this, for example, through the industry, through banking, with concepts such as benchmarking. And in fact, composite measures are superior to individual measures. We see this related to mortality. We see this related to hepatobiliopancreatic surgery. We see this related to pancreatic surgery alone. So if we think about textbook outcome as a composite measure, individual outcomes are combined with this tool into a single metric that allows a comprehensive assessment of overall quality of care, and in this case may represent the optimal hospital course. So for example, if you think what is textbook outcome is a definition that if we think that there is no postoperative complications, no prolonged length of stay, no 90-day mortality, and no 90-day readmission, this is, in fact, a textbook outcome. This is the definition of a textbook outcome. And this is a metric that aligns with most patient expectations around the optimal experience after being operated. Although this can also be used to assess, for example, not only patient-level outcomes, but hospital performance, center designation, quality metrics, and even healthcare costs. For example, in this study that assessed over a 12-year period at several major hepatobiliary centers the results of textbook outcomes, and this is studying intrahepatic cholangiocarcinoma and hepatocellular carcinoma in 15 major HPB centers. These were the metrics that were used: R0 resection, no postoperative complications, no 30-day mortality, no prolonged length of stay, no 30-day readmission. And in this paper, 944 patients with hepatocellular carcinoma were studied, and more than 1,000, almost 1,000 patients with intrahepatic cholangiocarcinoma were studied. And what was analyzed was, in fact, that textbook outcomes for hepatocellular carcinoma were around 68% of patients, and for intrahepatic cholangiocarcinoma, 62% of patients achieved a textbook outcome. And you can see here the textbook outcome variation over time and its various components. And you can see, for example, that in this paper, this was correlated with overall survival. So a good textbook outcome correlates with survival. The conclusion in this paper is that actually around 60% of patients achieve a textbook outcome in these pathologies that we are studying here, and that textbook outcome rates did not decrease over time, besides more extensive resections and worse profile of surgical patients. So this is a chance to optimize the results when we look at the operative outcomes. We also know, for example, that dedicated care centers, cancer centers, are more performant in terms of textbook outcomes. And so we can see that in this universe of 21,000 patients submitted to HPB surgery, we can see that dedicated cancer centers achieved a better outcome compared to non-dedicated cancer centers. And it was, in fact, textbook outcome was an independent variable of prognosis in dedicated cancer centers. So we see with this that roughly 1/2 of patients who underwent HPB surgery did not achieve a textbook outcome. And the likelihood of achieving this textbook outcome was higher in dedicated cancer care centers, thus supporting, in fact, what we always say, that referral centers for this type of patients is very important. In the literature, there is a lot of publications in this subject, in a lot of variability of diseases. But in fact, we think in textbook outcome, and we think that is a patient that has no postoperative complications, no prolonged length of stay, no 90-day mortality, and no 90-day readmission. And we call this a textbook outcome. But in fact, you look at the papers, and the definition is not the same in every paper. For example, for HCC, you can see that, for example, its absence of 90-day mortality. and the textbook outcome is 24%. We see, for example, for intrahepatic cholangiocarcinoma, you see that the textbook outcome is around 25%, but the definition of mortality is 30-day mortality. And you see that there are a lot of small differences in the decision of what is, in fact, a textbook outcome throughout the literature. There is even a consensus made by a lot of people that are here in this room trying to define what it is a textbook outcome in liver surgery. So this is clearly needed. If you use textbook outcome as a measure, you need to have a consensus of a definition of what is in fact textbook outcome. So if we compare benchmark with textbook, I would say textbook outcome is an all or none composite measure, is more patient-centered. It can be regarded as a hallmark of overall quality of care, and increasing rates of textbook outcome should be the goal when you aim for high-quality surgical care. Benchmarking, for the other hand, aims to identify the best achievable results by selecting benchmark cases. We could call them low-risk cases. And the difference between the performance and the benchmark values is the potential to improve. So this is another way of looking at this. Benchmark, I can say, perhaps it's not such an easy concept to understand. It has a multiplicity of variables, and we can consider the benchmark as a standard that others may be measured or judged. And this might be confounded by the differences of what should be regarded the low-risk cases. In fact, the problem is a little bit the same as in textbook outcomes. And, for example, a benchmark cutoff that is defined as the 75th percile of medians is not such an intuitive matter and may lead to some benchmark values that are not, in fact, so optimal. For example, there is a paper that shows that the benchmark cutoff value for a Whipple procedure is 7.5 hours, which seems to me that is probably too much. Textbook outcome has few variables considered. In fact, they vary between studies, and as the number of variables is increased, the likelihood of achieving a textbook outcome diminishes. And we can say that textbook corresponds to a standard that is prescribed or widely held by experts, but there's still no consensus in the literature, so what is regarded as optimal. So about textbook outcome, and in conclusion, textbook outcomes may provide a more realistic assessment of patient-centered post-operative care. It represents, in a way, the optimal experience around the surgical episode in a patient perspective. It may be a good and a comprehensive estimate of quality of perioperative care, and it may be regarded as the outcome that surgeons should strive to achieve for their patients. Thank you. First of all, just wanted to thank Tim Pollock, because he has a lot of work on this, and he, in fact, was one of the co-authors of this paper. Thank you.
Okay. Thank you. Now, Pierre.
So Hugo, very well done. I will try to do that on a debate matter. I think it's an important topic. The textbook outcome, sorry, the textbook outcome came from the US mostly. Tim Pollock was one, not the only one, coming with that. And in Europe, there's not some American here. We are a little bit more differentiated. And what you point out at the end, I will go to the benchmarking. The textbook outcome is very subjective. You know, you have 30-day, why not 3 months mortality? And it makes a lot of variation. You have only one value. It's not really clinically relevant. You have yes or no. So it's not much insight, I think, in terms of outcome. And in addition, what we want to do is to look at quality and to compare. That's the two things. So I would just have a short summary about the benchmarking, and at the end, I think it should be an interesting debate, how it works here. Should I use this one? before, when I gave my talk, there was that there is a clear sabotage from Hugo, probably, or is that here? Maybe it's here. Aha, see? That's, you know, if you just go intuitive, without AI, you can do it. Okay, so I have a few slides to give an overview of what we mean with benchmarking, and then I think we really need a debate on that. So we talk about quality. I mean, the idea at the end is evaluate the quality of our work from many different perspectives. So if you just go to a dictionary, it's relatively simple. It's something when it is compared to another things like, and how good or bad it is. And we can compare that. That's really the message of that. So if we have here, I show this as a 3 centers or 3 surgeons or procedures, there are differences. And how, can we compare, how can we estimate in an objective way the gap between center 1, 2, and 3? And as everybody knows, maybe center 3 is the best one because they have only very difficult cases. So just looking at outcome is in no way enough to have this concept. I mean, one thing that is absolutely clear, benchmark is not the average. It's used in many administrative databases. In the US, you take the average of liver transplant. You're above the benchmark. Below, that's for sure. That's a wrong definition. This is not the average. So the idea of this concept of benchmarking is to take the best centers, the best player, the best whatever, what they achieve, and to see if we are close to what the best people can do. Certainly not one best center. If we take, for example, perihilar cholangiocarcinoma, there was one center, Nagoya, with a 1% mortality. When you look everywhere else, you have a mortality with 8 or 9%. So I think it would be wrong just to take the benchmark one center, but you need to take somewhat the best center. And here there's always some definition, what means best, etc. And we'll go a little bit through this. So the idea of the making, you have the number one, the making, how do you identify, how do you make the benchmarking, and the number two is how to use it. And I will go a little bit on both sides. The first is how we do it. So the first, this is this circle or this way. First, we need to identify the best. And we will go here to identify the best center, or surrogate, the best patients, and what the best result, because we do benchmark for a procedure. Then you establish this benchmark value. You come with we'll talk about that. Then you have compared to something else, non-benchmark patient, another procedure, and then you have a gap, and then you have material or evidence how you can ameliorate this. So the reference center, that's where the best. What are reference centers? So they are surrogate marker is volume. We know that's not enough, but that's surrogate marker. You have different criteria, multidisciplinary team, prospective database, etc., that can identify the best center. Then you need to identify, I will give you an example, the best patient or the low-risk patient or the optimal patient. We can discuss after. I think it can be done in a relatively reproducible way in the best center, and then we go to this benchmark value. So if we go to the ideal or best or optimal cases, so the center, that's the high-volume center, low-risk patient, the outcome will come, and then there's another question, very important, this is very poorly addressed in our literature, is the follow-up. It was a tradition to have 1 month follow-up based on nothing today, or discharge follow-up. And we know that we have only a small proportion. One of the benchmark was done recently comparing one procedure, which was anatomic resection, liver resection between US and Asia. So in Asia, they stay 10 days in the hospital, in the US 2 days, but when you use the readmission rate, after that it was 25% in the US and 1% in Japan. So this is, you need to know the follow-up. The follow-up is very poorly described, and with the benchmark study, we can identify the follow-up. I will give you also some example. So what parameter we look at? Just look at the textbook outcome that tell you I did no complications, so liver transplant does not exist. There is no single liver transplant, basically, that has no complication. Anyway, so here you can look at ICU stay, you can look need of transfusion, you can look at duration of surgery, whatever that's clinically relevant or economically relevant that has a meaning for the patient. We, of course, always look at mortality. Fortunately, it's pretty low today. And then you look at morbidity, which become very important because as suffering for the patient is more cost, etc. to that. And there is grading system or the comprehensive complication index that give a value of the overall morbidity, and you can benchmark for each of these. And at the end, you can really compare everything we can, I mean, as long as you have the data, you can look at all these different parameters. No, I mean, that's Hugo mentioned, and that was not a Delphi or whatever. It was a small group with an epidemiologist. How do we define the cutoff? And the idea, as an example here, you have these centers. Let's say they are expert centers, center of excellence. They need to come from the 3 continents in the definition. And for this procedure, that's the value. So the comprehensive index is 0, no complication, 100 is death. And then the middle, you have all the different values, which calculate based on the severity and the number of complications. The idea is that you have here from the center, you have variation here, you have the outlier, you have the median, and it was decided, that's totally arbitrary, and in fact that might be changed, we decided if you are within the 75% of the best cases in the expert center, you should be considered as a benchmark. That's okay if you are in this value in this. Of course, the selection may change. We could take 50%, but these many benchmark studies have taken this 75%. I give you briefly 2 examples of this study that started about now 10 years ago. Has been repeated by others, and you can see number 1, you have many authors because you involve many centers with prospective database and a lot of work. This work was done by Xavier Muller, who now is working in Lyon, France, and the idea was benchmarking in liver transplant. What are the benchmark value in the field of liver transplant? So he took 17 international centers from all around the world, something that's not too old. So here it was published, I think, 3 years ago. So that was 2010 to 2015, to have at least 1 year follow-up, 3 continents. We were looking at the largest program, which was voluntary participation, minimum 40 liver, etc., and well-defined low-risk cases. And of course, you need some thinking. So what was here the low risk? You can see low MELD, no risk factor that we know, portal vein thrombosis, liver failure. We were looking also at the graft here, combined here to only DBD, no split graft, and there was this bar score with a balance of risk. So it's really the great cases, the optimal cases, at least on the paper, preoperatively. You cannot define postoperative preoperatively. And here, with the many benchmark study, it's about a third, 25% or 30% of the patients are in fact benchmark, and 2/3 are above benchmark. So from this series, it was about 7,500 patients collected in the 17 centers. 2,000 were and qualify as benchmark cases. First information that we have with that, that's the CCI, but we look at other things, you can see discharge, so you have a follow-up, 3 months, 6 months, 12 months, it increased. It increased, and you have a significant number of complications between 6 months and 1 year. And the first conclusion was, and that should have some relevance in publication, if you want to give data on liver transplant, you need 1 year. So the New England paper on the whole is only 6 months. But okay, it was important enough, but it was not 1 year. That's the only one you have to 1 year. The liver resection is 3 months, and the pancreas is 6 months with the same data. I would not give that the data, so here was 6 hours liver transplant, ideal case, the cutoff, 3 units of blood, 4 days in the ICU, 18 days in the hospital. Benchmark value cutoff that we can compare single patient or a series of patients. I will not go here. That was a Mac from BASIC, that's a bit, but we can see here complication. Basically, everybody has at least one complication. Grade 3 was about 60%, etc. Mortality 9% and 1 year. So you can put anything as long as you have credible data to look at this. Another example, actually just 2 examples, which was done by Patricia Velasquez Sanchez she's now in Barcelona. She came to us for a fellowship. Same thing. You can see here a lot of centers. And the idea here was to do benchmark on Whipple. And we wanted to do it at a time before robotic is here or laparoscopic to see what we can have. So she collected, she was several, 23 international centers. You can see well distributed here, many in the US, and in the US you can see most of that we were lucky, of the top centers were able to participate, like Johns Hopkins and many others, with a few in Asia, and most were in Europe. That's the data here. Again, a third of the patient about where I don't see this figure here. It's really AVT, okay. A third of the patient, I think it was also the 5,000 or 6,000 patients, and a third were benchmark cases, 2/3 were not. That's the surgery that were mentioned here, but that's the data, 7.5 hours. That's the real data, best center, 7.5 hours, no blood transfusion. In fact, 1 day in the ICU, 15 days in the hospital. In this. So I would pass on this. You have other information like the fistula, 19% BC in this series. And you can also, for subgroup in terms of soft or hard pancreas, you can play a little bit as you want. And the readmission rate is 21%. It's relatively high. And here difference between the US and here. Now, when we do this study, you discover something very interesting again by observing. That's the 23 centers that you have here that participate. They are anonymous. That is part of the game also for this. And they qualify as centers. And in blue, you have the benchmark cases, so the easy optimal cases, and the total of cases. 2 examples here. You take 2 centers who have about the same number, right, about 350. But you have a huge difference in the number of benchmark versus difficult case. So the center number here, the center number 13, you can see they have very few benchmark. They operate mostly on difficult cases. And you have the other one here was about 75% benchmark. So here you don't need multivariate analysis, sophisticated, that you may not trust. You visually can immediately see how they do easy cases or not. Huge difference. Is that a difference in outcome? Yes, there was. Very interestingly, the center operating on difficult cases, very few, had 3% fistula, and the other one had 11% fistula in terms of severe pancreatic fistula after this pancreas. That's a very interesting observation, also with consequence in the United States, and it comes with a new surrogate marker, failure to rescue numbers. If you operate on difficult cases, you are better. That's a surrogate marker. So if you look at the centers and they have 90% non-benchmark, they are probably better than any other center. It's intuitively also correct because maybe more skill, the ICU, etc. But now it's a surrogate marker. When you investigate, you can check. If they do 95% benchmark cases, is that a choice? Is what they receive? I don't know. But that's an interesting, that was a novel finding. And here you have one center here, so to do with learning or whatever. And we have another center here. Sorry, I think I go back here. The number 23, I mean, they let me know who that is. That's Johns Hopkins. So a lot of surgery. And you can see also they operate mostly on difficult cases, probably refer for all the US. But the fistula rate, I think, is 6%. So is in between. We'd expect very low, but in fact is 6%. And it may go to this graph here, the study that we know the learning curve, we have a plateau, what minimum you have, but there is probably a breakdown point, so too much is too much. So very large series, and we see that in liver transplant, many fail. At some point, for whatever reason, the quality of the risk may become higher. Is that waiting time longer? Is that too many surgeons? I don't know, but that's an observation. Okay, I will go. There has been now just many studies that they've done with this methodology. I will pass here, but you can see many papers published in different journals, presented at ASA, ESA, and outside from about 10 different groups that they've done that, and 3 are coming that were presented this year in Bordeaux on anatomic liver resection, one from Korea on total gastrectomy, and also international and living donor liver transplantation. We have another tool here that we compare for the first time, whatever that may mean, esophagectomy with liver transplantation. How do we know today what's the outcome of one? We can do it now. Of course, there are different definitions of low cases, but we can see here, for example, here that esophagectomy has a mortality of 2%, but one of the highest morbidity. So you have new observation. We can think, but that's value that now are available to this methodology, and you can see pancreas with liver transplant, with redo liver transplant, etc. Well, the last is how to use it. So now you have seen how we can do it, or how we have this benchmark. That's international work, a lot of work, but then we have this cut of value, and how we identify the gap and how we can do it. So here, very relatively simple, that's what we are using. Every cases that has a CCI or whatever value you think is important above benchmark must be discussed in the morbidity mortality conference. Just be presented and discuss why they are not in the benchmark value. They may be not benchmark cases, and that could be the case. And that's the way we present the things now. We have the benchmark cases, so the optimal cases, and the non-benchmark cases. Do they have a benchmark outcome and non-benchmark outcome? So it is four categories where we can look a little bit how they are. Sorry with the Mac, but you can see here, that's this Whipple, benchmark outcome 16, benchmark value is 22. Okay, nothing to say. We are below the benchmark. Here we have a non-benchmark outcome in a patient with benchmark. This didn't need to be discussed. It was an ideal cases why he had an outcome was different. That's what we would expect in the best center. And we can analyze the non-benchmark cases. If they are within benchmark value, nothing to say. They were more difficult case, but despite that, a normal outcome, etc. Okay, so I've done that so that I can pass on this. Okay, that's the goal of that. So here, just to finish for the conversation, here the benchmark are many clinically relevant endpoints that you can analyze, that you can see the gap and you can correct it. And the textbook outcome, from my perspective, is subjective. Many papers have different definition. The ideal case that has no fistula, nothing, is pretty rare, and it's just one threshold. We may miss many information on that, and in my opinion, there is no irrelevant Delphi study to say what's a textbook outcome, as from my perspective, not much value. I just want to give credit that many of the people in the team, particularly Professor Milo Puan, who is the head of biostatistics and epidemiology in Zurich, and that was really the combination of working together on the statistic and the clinical relevance that many of these people, and there has been 4 PhDs that have been done on these studies, so that it also be good academic. I don't do my advertisement again. I already did it. Or should I do it again, Laurence? No? Okay, thank you.
Thank you. Now, David, there are 2 discussants. Who speak first?
Too many, because I think that these 2 friends had studied deeply this issue. And in my opinion, it's not a great discussion. There was some bias here because Professor Clavien exposed 3 times more time than Hugo.
Well, and we're free to use it. He has less to say, that's the reason.
And I think that he's a fanatic of Ben Marching, and he has published a lot, several papers, and today he promoted this Congress. So, in my opinion, for a surgeon, I never understand. I think that benchmarking is what we have to achieve as a gold standard. But and institutions and in different issues. But for me, as a not very clever surgeon, is much easy to understand the result of the textbook. Sometimes I find in the different study we participate in some of these benchmarking studies, and sometimes for me it's not easy to compare what is our dire practice every day with the result of the benchmarking. But it's very easy to compare our result with the textbook. But they study this deeply. You know, all these guys, this team that show Pierre here are statistic guys who work in that. So I can criticize at all because I don't know as much as he knows this issue.
I remember we are in confrontation. This is textbook outcome versus the title versus benchmark. Eduardo,
yes, can I add something?
Yes, please.
And Hugo put some critics about benchmarking. And Pierre not say nothing about a textbook. He say he promotes just benchmarking. So
No. He said,
that's my opinion.
No, he said something again.
No, it's not verdad.
Okay.
At the end, I showed the stuff.
Yes,
The last slide was...
So, in this confrontation, Eduardo give a point to textbook outcome. Yes. Okay. Please.
Congratulations of both of you, because the talk were quite interesting. Personally, I think that benchmark is is easier to compare centers and without trying to, can I say it, without trying to be the best one, just to be in the middle in the average. One of the questions for Marques is that with the textbook outcome, are you not afraid that some center try just to select too much, just to achieve the best outcome, and all the 70–80% of patients that can have, of course, the textbook outcome? I mean, I'm afraid that the textbook outcome may encourage a patient selection, just to have good results. In the case of benchmark, you have an average, as Clavian show in the different papers, and so probably it's a better way just to have an idea of what you should have when you treat patients for different diseases. But I have a question for, another question for Professor Clavian, is that regarding the, since we try with benchmark or textbook outcome just to give the main outcome, the best quality of cure for patients, do you think that we should introduce even the problem of the percentage of mini-invasive surgery that you should perform when you treat patients for ACC, pancreatic cancer, or something like that? I mean, we have just to compare only laparoscopic approach, open approach, and to see which is the benchmark, or we have also to try to, how can you say, to push a center that some percentage of patients should be treated by mini-invasive approach. It's just...
Well, thank you. It works? Yeah, thank you. I think the idea of the benchmark is to give a reliable cutoff for comparison. So you don't want to mix. So the idea of the Whipple, for example, we decided to do that now because it would be more and more robotic, etc., to evaluate. That's the benchmark. And now you can do robotic Whipple, and you can do the same methodology and compare. In this paper, Patricia Velasquez, also in the same center, look at the robotic as a control, as an experimental group. So you have the open, and we found at that time the fistula rate was 4 times higher in the robot. That was not the main finding of the paper because that was not the question, but the observation, the mortality I think was 3 times higher, and the fistula rate was 4 times higher. Just a question at the end. So we have benchmark value. We look at the data, even non-benchmark on robotic, and you can compare. But I think we should not mix too many things. You have a question, I mean, redo transplant or gastrectomy, the valuable endpoint that you have. And just the point I want to make, in a benchmark study, you can put textbook outcome, no problem. You put as one of the endpoint textbook outcome, and then you know in this series how many have this textbook outcome. You can put different definition of textbook outcome, and you will have also the data for this.
Well, I think you're right. If you select the textbook outcome, there is a danger that you might select too much your patients in order to have good results. But on the other hand, you can add another issues to the textbook outcomes in order to be more correct and to have a value that is more accurate. But the other thing that I really think is an advantage in the textbook outcome is that when I look at the way benchmark values are calculated, I really don't understand. I know that this is the 75th percentile that corresponds to the easiest patients. But then you show me, for example, this paper when you see a lot of centers And the percentage of centers that are outside benchmarking is clearly more than 50%. So how can this be? You probably have an explanation, but it's to start, it's difficult to understand.
Fully agree. I mean, maybe I need to give the main criticism of the benchmark because nobody has done it yet. In some way, is the quality of the data that you collect, right? I mean, here we go database, etc. So you need to have absolute. So I think this is a methodology for the future when you have independent database and then you can have real-time data. Now the 75%, we were around the table with Milo Puan and we were discussing. And we did not want to have unrealistic value that was real world. I want to compare if my data is as good as the 75% of the best center with the best cases, it should be okay. Totally subjective. But now we have recommended that to give also the 50%. And for oncologic result, it makes a big difference in terms of the value. So maybe it's time to have a consensus and decide whether we want 75 as a cutoff or 50. Our recommendation, because it is to give both data, but we consider still 75% as the realistic benchmark to achieve. Again, if you within the 75% of the best high volume center, we should keep you in peace. But
so Pierre,
when we compare two things, we need to say for what?
Yeah, that's my question. When you are comparing, you are evaluating resectability. For who? Percentage, okay, the benchmarking in resectability of a colorectal liver met. How you evaluate this?
I don't think we have that.
No,
I don't know what you talk about.
You.
I think we
can be done?
I cannot follow you, Eduardo, sorry. But the benchmark is mortality, ICU stay, blood transfusion, length of stay, complication after 3 months, after 4 months, whatever is. You don't hurt anybody if you have things that are not for others. But I like to know just the mortality, just very simply, the mortality benchmark. You can compare between esophagectomy, whatever, that's relevant. The resectability, do I have that as a value? Where? In which one? In which benchmark?
It can be done.
Well, I mean, as long as you define things, I don't know. I mean, the resectability, I think it's a very subjective and difficult way. We look at the procedure. The question is Whipple. So you don't look intent to cure or whatever. You look at an intervention. So it's very surgically relevant. You do a Whipple. And then the last one we did is also benign. The anatomic we discover, because you do that, there's big difference between benign lesion, which was only 20%, and malignant region, well beyond just the type of surgery. So there's underlying liver disease, whatever. So at the end, we conclude you need 2 benchmarks, one for benign liver resection and one for malignant liver resection in some way. But I think the goal of the benchmark is to be clinically relevant, to have a meaning for a center, for a patient, and to see the gap. That's the idea.
That means you see, for center and for patient.
Yeah.
Individual.
Yeah, we can take a group of patients, yeah.
This is clear. And for you, the same?
I think for centers and for patients, we can use them for both. Sorry. So for centers and for patients, we can use textbook outcomes for both. We can use the percentage of textbook outcome as a measure for the patient, and we can use it as a measure for the center, because a center that has 90% of textbook outcome, providing that the amount of patients and the type of patients is the same, is a way of showing the quality of the center. And on the other hand, you can measure resectability, for example. I won't say resectability per se, but you can measure R0 resections. This is a way of measuring objectively.
R0 is a benchmark value in every
and
one.
the textbook
is R0.
also. Yes.
Yeah, but the textbook is diluted. The textbook, you take and say good, bad, that's it. You don't know what it is. Either you textbook or not textbook, while here you have for the perihilar, you have R0 resection or whatever you want to put.
I think in that sense, it's not so different, because R0 is R0. So you have that in textbook and in benchmark. And in fact, it's just yes or no.
No, but we are missing a point here. If you do the benchmark, you can be in the benchmark for 12 parameters, but not for R1. So you focus on your R1, that's it. The rest is perfect. In the textbook, you've not this information.
We need your question, your remark, the microphone. Laurence, you are
late. It's too late on the side.
So in both systems, I think one crucial point is the quality of the data. Who will control the complications, for example, fistula rate? Who will control this? Because if all hospitals will be evaluated on benchmark or textbook, somebody has to control the quality of the data that the people will put in. And who will do this?
Well, I mean, we just completed a consensus conference last year, which was published a month ago in Nature Medicine. That's jury-based recommendation, not from anybody of us with bias and expertise. And this is, of course, one of the main points. I mean, there are many points on that, is the quality of the data and the requests for every hospital to have data manager independent to doing it. And now, in a time when there's no money, it's very difficult. What we know, if it's done by the resident, 30% failure. If it's done by the expert, will not work. If it's done by some culture, every complication for the boss is not recorded, right? So that also, this is the real world. And one of the big recommendations that's responsible, not of us, I mean, someone has to pay, someone has to understand, whether it's government, insurance, whatever, but he has to do independent, also from the insurance, because there are many other incentives. The basis, whether it's textbook outcome, whatever we want to look at or cost, you need independent people who do the data recording. And that's relatively easy for the complication. You can go in the chart, you have it. You just need to make sure that the collection is done properly. It's clear. But that has nothing to do with what but at the end, it doesn't cost. We save money. When you have no data, we've done so many things in surgery until today with zero data or case report or self-reporting. We all have done that. Okay, that's fine. We promote our center, our procedure, our money, etc. But if we go the global and the perspective of the society, of the patient, all that's wrong. That's what we still in the Lancet. We, a surgeon, we are a comic opera. And now we did, I mean, maybe I take too much time, we blame, but we did this today, the analysis of the literature, the data is a disaster. I mean, in top journal, New England, Lancet, Annals, etc., we miss most of the data in the reporting. I think a third of the paper doesn't even say how long they follow the patient, and they publish in Annals of Surgery or whatever. So there is really, if we want to be credible, not among us and showing nice videos, it's fun, but if we really want to be credible, we have to change a lot.
Question? What is, if you use for individual, for a surgeon, you may use this for a surgeon. At the last ESA meeting, you remember there was this surgeon from Korea. South Korea, yes, South Korea. And he said that his department, every week, the surgeon who did the operation, there were 6, I think, they have a meeting, and they evaluate what they do on each patient. And they have a note. If the patient has a complication, what type of complication, according to your classification, the length of the hospital stay, and they have a note. And one is the best, one is the worst. And they ask to the one with the bad note to improve the week after. It is like this. And by this way, they improve. This is application of the benchmark.
Well, he presented. That's a CCI. So what he's using is the Complication Comprehensive Index. That's Hanquan, who's the largest gastrectomy center in the world, and he did that for many years. Yeah. And then every surgeon, they calculate this complication index, and then, I don't know, every month they do that. It's written here. I don't know, maybe. And the idea, of course, they want to make people aware and correct themselves. But here also, you need to know if they operate more difficult cases, etc. There's always this bias to minimize the CCI to do only the good cases. But he's using that as a tool. I think he has 6 or 7, as you say, 6 or 7 surgeons, and they have their CCI to monitor the performance.
Mm-hmm. And I think we can use this for that way, for good reasons. If you use benchmarking, you can use the increase of results in the benchmark cases to evaluate quality, as well as you can use the increase in textbook outcomes in the same group of patients to evaluate quality.
It's not to discuss between you. What they are doing? Impossible. We were discussing. Okay, but you did not listen what they say. Okay, continue.
Oh, I would say precisely that. I think we can use both measures of outcome, because for textbook outcome we can use it. The percentage of textbook outcome is a measure of quality, and the increase in quality of care in the benchmark cases is also a percentage of quality. So the difference between these two values is what we have to achieve.
I mean, one is to evaluate the individual, the surgeon, and two, to evaluate the institution.
And the procedure, you can evaluate whatever is, you can evaluate liver resection with ablation, whatever, yeah. You have granularity in the data.
Okay. So, Discussant.
So I think Eduardo need a drink now, something.
You have something to say, or you finish your discussion between you?
No.
Abandon discussion?
No discussion. No.
So continue. Go on. Eduardo.
We were trying we continue the discussion regarding resectability.
Okay,
And? No, that you said that it can be evaluated in benchmarking.
Please give the microphone
To understand about textbook, particularly
we
benchmark.
don't
Benchmark is the heterogeneity, that what you show centers with a high proportion of benchmark and very small. And if I understand, in center where there is a lot of non-benchmark, the textbook should be low, right?
Should be low, yeah, that's right. There are more problems.
Low.
Yeah?
And because we have in France, we had, that's finished now, a ranking of hospital. This is a benchmark. They use some criteria, which are the number of cases, the severity of the patient, and the hospital stay. And then they ranked all the hospitals in France. This is benchmark, but yes, it is. Less than yours, okay. No. But I think that the interesting is to implement the severity of the case. So textbook or benchmark is not, it's for easy case, for both.
No.
See, benchmark, when you are in benchmark,
textbook does not differentiate anything.
Textbook is when everything is okay. So it's easy cases.
Not necessarily. It's the percentage of patients that go okay. It's not necessarily the easy cases.
Okay.
It's late. It's late.
Late.
It's becoming late.
I propose to stop.
I'm not convinced.
It's too late.
Okay.
Bien joué, bien essayé.
Now, this is very clear. Who are convinced for something?
Pietro.
Ah, Pietro.
I find, yeah. Want to speak? Vote. I am convinced. I am completely convinced about the benchmarking. I mean, I found the benchmarking papers extremely useful just to gauge how I was performing and how I should do it. And in particular, if you start on a new center...
Il est brillant.
Hein?
Non, c'est...
She confused me a couple of times while I was talking, so I know that. No, she was making faces while I was talking. Of course you were. But anyway, I'm convinced about...
Elle a dit que tu étais suisse.
I was completely... I mean, when the benchmarking paper on pancreas came out, I saw exactly what I should be doing to have my center do things the proper way, and extremely useful. Like, we'll talk about other papers of yours, Pierre-Alain, but this was completely convincing for me. And probably other people who have the responsibility of a center or took up the responsibility of a center recently found them very useful. Maybe not. Thank you. Never argue with fools.
No, but maybe just one way also the idea to start, the start was to prevent this multivariate analysis, right? All this statistic manipulation. I mean, as a surgeon, we wanted to see it. That was the idea. It's okay.
Oh. Alors, what you want, Eduardo? Sit down, sit down. Sit down, sit down. Sit down. No. So, at the beginning, I see that as this benchmark versus textbook.com, I would like to have a vote at the end. Do you think we may vote? Yes. For what?
The future we will see.
Yes, one or the other. No. No, what I think is not. That means. That means.
Both are very good tools. The textbook outcome can be included in the benchmark. That's it. If you
They don't want to vote.
I think.
Okay.
I think that at the end, the title of the face-à-face was not good. It was textbook outcome and benchmark.
Voilà.
Without opposition. It's okay?
Back to the past.
Okay.
Okay. Thank you.
Thank you. It's finished.